with the testing numbers, does there need to be a benchmark minimum tests to meet a benchmark, particularly for Metro Melbourne, in terms of it might be 5 cases an average, but do you need a certain amount of tests to make sure that's a real number?
There are some WHO guidelines for numbers of tests that should be done for every case detected, and we're meeting those for all of our local government areas across Victoria, but we want to do better than that. So we're not setting benchmarks per se, but we are doing a kind of traffic light system where we know that there's a higher case numbers or more transmission. We want the testing to reflect those hotspot areas in particular. But it's absolutely the case that all of those postcodes, LGAs with 0 cases, and maybe 0 cases for weeks and weeks, need to have a baseline level of testing that should be maintained. So we haven't got a fixed number, but we're certainly looking at that comparison of how much testing is being done against how many cases, how many active cases, how much transmission's occurring.
And you're comfortable with where it's at the moment?
Oh, today is not a day that is ideally meeting the kind of testing numbers in terms of the 24-hour period reported beforehand. So really like to continue to push that. You know, we've got 9 of today's cases that have come from Hallam Narrawarren area. So I'd say Casey local government area. Today's your day to think about, have I got symptoms? Have I had symptoms recently? Have I been tested? And absolutely get out there and get tested. Because that risk will change over time and it will change geographically, but we certainly want to push it each and every day.
Are you worried about a cohort of people who don't want to get tested because they're worried if they test positive, not actual effects of the virus, but the factors that might keep lockdown longer? Are you worried about that?
Well, the issue about lockdown is the pathway out is testing. So, you know, I really want to emphasise for people, outbreaks will occur if you're not testing, and they'll be detected. They'll be detected as people turn up to hospital. They'll be detected as some of the most vulnerable become manifestly unwell. So testing is our pathway out of this, and testing is the way to make sure that any restrictions that are in place are in place for the shortest possible time. So testing should be seen as the way out more than anything.
As we open up, will we see more of that sort of rapid testing, the sort of one that turns out around in a few hours?
Yeah, we're absolutely looking at point-of-care testing or near real-time testing where you can turn around a result in 20 or 30 minutes. I think that makes a huge difference. It makes a huge difference both in terms of managing that person clinically. If they're positive, you know to isolate them, how their care needs to be managed, but also in terms of that contact tracing. You take off 12 hours between couriering swabs to a path lab, the turnaround time for them to process those swabs and then getting the results in. If we can have a point of care test that's done, an iPad, a smart form notifying the department all within 30 minutes, that takes hours and hours off our contact tracing time period. So I think it's there are a bunch of innovations, the spit test, the saliva test, but also the rapid blood point of care tests that can turn up the antigen, and others that we're exploring.
Is there a particular cohort or demographic that rapid testing would be kind of targeted at? Or
I think we just look at the fact that people will come to different testing sites with different motivations and different opportunities, and if you're capturing some people who otherwise haven't come forward for testing, maybe because they didn't want to take a day or 2 days to wait for that result, maybe because they're the kind of people who want that instant result back to them so they know exactly what they can tell their family or their household and go about their lives. If they're people who aren't testing now and a rapid test means that they step up for it, fantastic. But also anyone who's presenting to an emergency department, you don't want to have to go through a long process of testing there if you can turn around a test quickly. Same in general practice. If you can turn around a test quickly and give someone that reassurance, that's a fantastic thing.
Our average is around 54.4 at the moment. Where are you expecting that to be at the end of this week?
Look, it'll drop below 50 by the end of this week, I'm sure. If you look at the 14-day period before today, it's been in the 150, 170 kind of mark. But I've seen the unknown acquisition cases, the 14-day total, continually drop over recent weeks, and in the last few days, it's 4 or 5 per day. So again, if you look forward for the next 2 weeks, it should be in the 50, 60, 70 mark, which is obviously a positive trend. We don't report each and every day the mystery cases because they take 2 or 3 days to resolve. But that 14-day total, that rolling 14-day total, is something that should be tweeted today. I know I promised yesterday that Vic DHHS Twitter handle will be reporting that 14-day total for regional Victoria, which is less relevant. It's almost moot. They're going to get there tomorrow, all things being equal. But for Metro Melbourne, it'll be useful to watch that number ongoing.
And so is that September 28 date? You said previously it was set in stone. Is that still the case?
Yes. We need that time for the kind of settings that we have. But, I'm very confident we'll be in that 30 to 50 range for average daily cases. But if it's in the 20 to 30 range, all the better, but we need that time for the policy settings to be in place.
Have you got any data on how many patients went to hospital, didn't have COVID and contracted it there?
I haven't seen it. It is able to be captured. VicNIS, our Victorian nosocomial infection surveillance system, has recorded patients' status in terms of coronavirus on admission to hospital, so we can interrogate all of that data and get an answer for you.
And is it safe for Parliament to sit this week, given there is a confirmed case in the security guard there?
We think so. So obviously the outbreak squad's been out. They're very happy. The case and contact management and outbreak management team have reviewed the situation in terms of close contacts. They're very happy about the risk being absolutely contained. All of those close contacts are being furloughed, and so I think it's pretty straightforward to open, but we would review that over the coming 24 hours.
Why is regional Victoria taking any longer to get to the third step if they're already below 5?
So they need that 14-day period with no cases of unknown acquisition, no mystery cases. At the moment, that 14-day period includes 3 mystery cases, but they will drop off as that 14-day period moves into tomorrow.
And just with the day one of bubble buddies for people living on their own, what's the rules, just to clarify the rules on masks for people meeting in their own homes, just one-on-one?
Yeah, look, my policy team recommended masks to be mandatory. Cabinet accepted that. I accept that. So that'll be the requirement.
You said before with the September 28 date that it's necessary with the settings we have now. Can you just kind of explain what that means? And is part of the logic on that kind of, considering we've got these tough restrictions in, just keep them in and try and quash it as much as we can? Yeah,
there's certainly, as the Premier talks to the issues internationally, and of course it's not entirely comparable. 500 million people in a continent with free movement between 35 countries is a different kettle of fish. But in Australia, with really restricted international travel, we do have this opportunity to get down to such low numbers that they are sustainable for months and months and months. They are not opportunities that will be easily available to Europe without constraints being in place for the forward period. I know that the UK's gone to meeting maximum 6 people outside. That will probably be in place well into next year. Israel's going through a lockdown. They've talked about 3 weeks, but they will have, again, I don't want to commentate on the appropriateness of their response, but they will have high numbers beyond that because they haven't got that opportunity to get to extremely low numbers. The same challenge in France and Spain that really rely on international tourism and travel to maintain their economies. We've got an opportunity to get down to extremely low levels, and now is the time to keep those constraints in place for the freedoms that we get, not just saving lives, which is obviously our key objective here, and avoiding hospitalisation and all of the consequences that we know that coronavirus has, and some are yet to be fully understood, but multi-system illness affecting kidneys and lungs and the nervous system and the heart, including of healthy people. Recent evidence of athletes who are getting MRIs that show that they get inflammation of their heart that might be a long-term disability or a long-term effect on their cardiovascular performance. For all of those reasons, we want numbers low. But there is absolutely a view that the hard bit now is really significant opening up and greater freedoms in the long term, which will not be available to Europe or North America in the same way, because they will have the challenge of hundreds to thousands of cases that they don't want to get out of control.
We'll be looking at quick steps after September 28th then, if we are able to really push the numbers right down and get towards those targets?
We will follow it every day, every week. So, those assessments will be made at each point in time. But, from what we have tried to model and what we have understood from how things have gone elsewhere and internationally, we need to get to the kind of indicative levels that have been laid out. But we'll look, as I've said, we'll look at what those cases are, where they're occurring, why they're occurring, and how we can be really surgical, if we can, about the interventions that are required. And if they're particularly focused geographically, or they're particularly focused on a setting or a cohort of people, that means that we can make some other changes for other settings, we'll do that. But they're the kind of indicative dates that I think will apply.
Can I ask about Hallam and Narre-Warren? That Casey area has been a sticking point throughout this. Now that the cases are lower, have you been able to work out what's happening out there, why it's...
There's certainly some community transmission. We haven't linked all of the households definitively, but they might be linked by a workplace that hasn't been identified. They might be linked by going to a single setting that hasn't been identified. So it is a call out to everyone in that local government area, and those suburbs in particular, to come forward for testing, because there will be other cases out there that we need to identify, and testing, as I say, is the opportunity to snuff this out. And in 2 weeks' time, I'll be standing up here saying Hallam has 0 new cases, or KCLGA has totally turned the corner.
Is there a demographic or community trend in those cases out in the south?
Yeah, there is. These are multicultural community members. It's not different to how it's been for our second wave in large part. And again, this is linked to the high-risk workplaces in lots of ways. So it's a community that are a priority for engagement. They're a priority for testing for us. They do the right thing, but they have some vulnerabilities in terms of where they're needing to work and how they're needing to work.
Is that engagement not getting through?
No, I think it's getting through very well. I've made an offer to personally speak to that community, having been to Afghanistan a couple of times over the years. I want to be able to, reflect on my cultural experiences and the fact that I know that, there are universal motivations that every family has to do the right thing to protect their own families and the wider community. That's absolutely the case here. I know they're motivated to get on top of this as much as anyone.
Are you worried that rules are being ignored out there?
No, I don't think so. I think there are genuinely, structural issues about workforce that make transmission more likely.
Public transport's going to work as we open up? Will there be additional measures we have to put in place on top of what we're doing already?
Yeah, a lot of it's been talked through already. It was talked through in the first wave. We'll revisit that as return to public transport happens, but we know that there'll be a longer term kind of policy objective to have people who can work from home continue to work from home. So I don't think the pressures on public transport will be what they have been historically in normal times. But we'll revisit them in terms of the cleaning and the signage and the awareness raising that public transport passengers will need to have, and some of the other scheduling arrangements that might be pertinent there.
There's been some restrictions that are eased today, playgrounds opening, you get an extra hour to exercise. Based on the first wave, or based on the evidence you have now, is there a risk that people kind of get a bit excited and take it too far? And if so, how do you mitigate that risk?
They're baby steps. We all recognise that it's not an absolute sea change in terms of what's opening up, but I think that's what we're trying to manage here. We're managing expectations. We're being really clear that outdoor activities are the lower risk activities, and that these small steps are the ones that will continue to keep us safe and keep us on a steady pathway. I know how keen everyone is to get to a different place, but you only need small numbers. I don't want anyone looking at the daily numbers by postcode and saying, oh, there are no cases in my postcode, what's the issue here? I'm sure someone in Wuhan in January said, we've only got 100 cases, why is this city being locked down? We can't have short-term memories on this. It starts with small numbers, it explodes, and then the place that was not infected, becomes a place that's absolutely overrun with cases. So we have to consider Victoria as a whole, and we have to all do the right thing, no matter what it looks like locally for us.
Question for either the Premier or the Minister. Why have you limited the grants for sole traders to people who have like a tenant or a licensee, rather than people who might be at home or their business is based on the road?
We heard last week, Brett, about the government wants to set up these local contact tracing hubs. Do you have any updates on when that might actually happen, where there'll be any more details on them?
It's certainly being explored now. So we are looking at how to establish a steering committee and some appropriate governance. It's not something we should rush into. I'm absolutely an advocate for those who are locally engaged with their communities being a really central part of how we go about providing the support to clinical care for people who are being looked after at home, as well as all of the other needs that they might have as they isolate or quarantine, but also the role, especially of primary care, especially of GPs, in contact tracing and in the clinical support of people. There are obviously community health centres and hospitals that can play a role there as well for some of the more difficult clinical decision making and for some of the more nuanced contact tracing. It's not a matter to rush. We're in a place now where our contact tracing is as slick as it's ever been, and the transition needs to be sustainable. It needs to be well planned and well thought through, but it's already underway. And so that engagement with primary healthcare networks and the hospitals and primary care is underway, but we need to do it in an appropriately stepwise manner.
GPs have said as well that kind of frustrated with delays. People that they know, they've kind of done a bit of contact tracing themselves. What do you think of that kind of decentralising and them taking the responsibility?
Yeah, I think to the extent that they can be empowered to follow up those patients that they know very well, those patients and their families and their circumstances, that's a strength. But part of the challenge has been people have been tested without nominating a GP. People have been tested and only their phone number has been captured. We're certainly moving to make sure that to the fullest extent that we can, we're capturing the GP name and details at the point of testing. And for people who don't have a GP, that we make sure that we can make those connections and get that liaison happening at the earliest possible time.
I don't know whether it would be one for you or one for the Premier, but after the delegation that went to New South Wales, what are kind of the key practical points you've got out of that, and what's the next step in potentially making changes?
I haven't seen the detailed report. It's still being drafted. I think the bottom line is there are bits and pieces on both sides from both jurisdictions in terms of what can be reflected upon. There were some gaps that New South Wales knew that they had that we share. We're both working on them. There were some things that we should both reflect on and try and improve. They're kind of at the margins where we're doing things in a not dissimilar way, but there'll be more to improve by virtue of that deeper exchange, and we're very grateful to New South Wales for having hosted, because they did a terrific job.
Very good.
Thank you.
That's all. We'll see you tomorrow. Thanks very much.